Hi, everyone, and welcome to episode 347 of your Tick Bootcamp podcast. The title of today's interview is Professor Mom, an interview with Professor Holly Ahern. My name is Richard Johannesson, and I had the good fortune and blessing of co-hosting this episode with our good friend, Tony Felice. Folks, we named this episode Professor Mom because Holly Ahern was a highly regarded researcher who pivoted over to the Lyme community and became one of the leading Lyme disease researchers after her daughter suffered from chronic Lyme disease. And Professor Ahern offered us a number of really powerful insights about the importance of using antibiotics very early on in your Lyme disease journey. She outlined for us a number of different interesting steps she's taking to participating as a professor and as a mom in the political events surrounding Lyme disease. And Professor Ahern is doing something really cool in addition to researching. She is mentoring tomorrow's leaders in the research community in Lyme disease. Folks, we're really excited to introduce to you Professor Holly Ahern. Professor Ahern, welcome to the Tick Bootcamp podcast.
Thank you for having me.
We are really excited to have you. And even more importantly than just having you, we also have one of our favorite friends guest co-hosting with me today. And I know our community is going to be excited to know two things. One, that we have Tony Felice back, who had a huge number of downloads when we interviewed him on our podcast. And two, we don't have Matt Sabatello because Tony's going to be so much better than Matt that we're going to have a good replacement. So Tony, why don't you say hi to the folks and remind them of what episode you were on last?
Hello, listeners. Thank you very much, Rich, for inviting me to co-host on the show. I was just on a few weeks ago talking about my Lyme journey. I'm an entrepreneur and a business owner, and it almost took my life. And since then, I've been battling chronic Lyme. And so we had protracted discussion about that. But one of the things I think I may have mentioned is that for a period of time, I sat on the board of an organization called Focus on Lyme. Focus on Lyme is a nonprofit located in Arizona. Yes, ticks are in Arizona. Many people do have Lyme disease who live in Arizona. And that's when I was first introduced to Professor Ahern. And we met through Focus on Lyme when she became the chief researcher for us and heading up all the scientific research being done to either identify or to develop a diagnostic tool that would be 100% accurate. And so she has been our chief researcher and chief science advisor. She's one of the most well-respected Lyme researchers in the world. She will talk to us in a few minutes about her background, but we are very, very fortunate to have her. She's super inspiring. And as I had said before the show began, Professor, how grateful I am and so many other people are knowing that you are a light at the end of many of our tunnels. So thank you so much for that.
So this is really exciting that we have so many smart people on this podcast. So I'm going to do my best to stay out of the way and not mess this podcast up while you smart geeks geek out on Lyme and all things that you've worked on together. But before we do that, Professor Ahern, please give us a little information about your background. Where'd you grow up? Where'd you go to school? And what ultimately brought you to the really cool place you are now where you're teaching and researching?
Well, I've been in New York most of my life, and I grew up here so when I say New York, because you are from New York and I'm from New York, but we might as well be on different planets because you are from downstate and I am from upstate New York. I grew up here, went to college actually at UAlbany and got my bachelor's degree in biology and medical technology and worked for a while in that field, and then went back to graduate school about 5 years later and completed my graduate degree. I actually, at that point, my graduate degree is in molecular biology, and I worked with E. coli. And somehow E. coli is a bacteria, and that actually led me to a faculty position in microbiology, which I'm currently a professor of microbiology at SUNY Adirondack, which is a little bit even further upstate. And there I am, I teach and I supervise undergraduate research, and a lot of my undergraduate students, probably because they can't help themselves. And I say that in a nice way because I don't want to say I force them into it, but I like to say that I lead them to research in Lyme disease. So I've had several of my undergraduate students go to graduate school to further their careers in microbiology, and a couple of them have actually chosen to go further into the field of Lyme disease research. So that, and that's a full circle for me. So I'm really happy that, those students were able to make that transition to it. So that's where I am currently. And my Lyme disease journey began about 12 years ago with my daughter, who was a nationally ranked athlete. She was in college. And she suddenly and mysteriously, after achieving All-American status as a swimmer, suddenly became very ill. I mean, she got sick. She was at college. She called and said, "Can I come home for the weekend? I need a weekend off. I don't feel well." And so of course, got her, brought her home, and she went to bed that night and really didn't get up again for about the next 6 months. So, and trying to figure out what had happened, this all happened in February, March, so Lyme disease was certainly not on anybody's radar, not the doctors that we took her to or anybody else. And, it was a good 3 months of me being a mama bear, I guess is what it took to, just keep asking more questions, getting more testing done. And honestly, it took a friend of mine who was in, Tony's space with a chronic illness as a result of Lyme disease to say, have you had her tested for Lyme disease? Which, it's like Lyme disease. As a microbiologist, what I knew about Lyme disease is what I was teaching my students. And I said, well, we didn't see a tick bite or any of these things. And she said, I know, I didn't either. Maybe you should go find out if she has it. And we did. And I had to ask for that test. And when the test came back positive for Lyme disease, we were all happy and relieved and just hoping that, now we have a diagnosis and Lyme disease. CDC says, a short course of antibiotics, 2 weeks of antibiotics, she's going to be back on her feet. Everything will be fine. Well, yeah, no, that didn't happen. And that's what happens with a lot of people. So, it was a journey, but, she grew a lot as a result of that. I wouldn't wish it on anybody. And in fact, about 2 years in, after she was starting to, get her feet back under her, and I just said, I can't let this roll. I can't let more people suffer the way, what my family went through. Issues with navigating the insurance companies, issues with trying to get doctors to do the tests that, were more accurate than others, which meant I had to find out all that myself. So it was really an eye-opener about medicine in general, and then also just, the issues with Lyme disease. But that's what brought me to advocacy. So as a teacher, what I did first was, all right, I'm going to go out in the world and I'm just going to start giving seminars on Lyme disease. So that's where I got started. And I also responded to a lot of things, especially in the spring around here. I'm sure that's true on Long Island as well. There's always articles about, oh, it's tick season and Lyme disease, this, and filled with inaccuracies. So I started writing op-ed articles in the newspaper, just responding to these things. And from there, a lot of people came to me to learn, just said, can you please get more involved? And that's really how the advocacy part was born. Here in New York State, I started a organization called Lyme Action Network, which is an education advocacy organization. And then, I met, which we can talk about later, but then I met Tammy Crawford in 2014, and nature took over from there. I mean, that was a pivotal moment in, I think, both of our experiences, and we haven't looked back since. And so we've got big goals for what we're looking at here.
So I'd like to walk back and unpack a couple of things with you. And let's first talk about parenting Lyme, right? So if I were a child who was living in a tick endemic community, I don't think I could be safer than if I was being parented by someone like you, right? With your background and your education and your training. I don't think I could want someone more capable than you to help me to stay safe in a tick endemic community. But it sounds like even despite your training and your education and your position in academia, that you didn't have enough information about Lyme disease to put your children in a position where they could keep themselves safe.
That is absolutely correct. And it was actually a shocking revelation to me that I knew more about Lyme disease and the physicians that were trying to diagnose her. And I have to say, my daughter was bitten by a tick, but it was months before any symptom showed up. I mean, a long time. So there was a tick. There was a tick bite. We saw the tick bite. In fact, my daughter found it and was shrieking her head off about the fact that there was this tick on her, which was the first time ever. And, you know, I removed the tick, put it in a baggie, brought her and my, you know, the tick to the doctor. And I said, all right, you know, because I was worried about Lyme disease. It wasn't like we didn't know about it, but I did what I thought I needed to do. I took my daughter and the tick to the doctor. He looked at the tick and shipped it off to the Department of Health. It came back later, which I thought they would test for the biological agents, but they did not. They just said, yes, it's a tick. And it's a deer tick, you know, the kind that could transmit it. So, all right. However, I was advised by my physician, and I don't hold this against him, but our family physician who was there at my daughter's birth said, all right, so you caught it early. You got the tick bite out. What you need to do next is wait and watch for a bullseye rash or flu-like symptoms. And if none of those occur, then probably she didn't get Lyme disease. And
okay.
This is the one moment in my life where if I could go back and change one single thing in my life, it would be that moment when I walked away. And because I said, shouldn't she be given an antibiotic? We don't want to take the risk we don't want to have that risk. And he said, no, that's not what we recommend. We just, wait and watch. If she's going to get Lyme disease, she's going to get that bullseye rash. So I walked out, and looking back, I should have sat down. I should have staged a sit down protest and said, I'm not leaving here until you write that script. Call the police. They're going to have to carry me out, but we left and watched every day for that bullseye rash, and there was no rash ever appeared. And she really didn't experience any symptoms till months later. And then it was not tick season, it wasn't Lyme disease season. And so her illness was misdiagnosed as a viral thing, some kind of, flu or something like that. And ironically, when the symptoms started, she also had swimmer's ear. So interestingly, she did get treated with a short course of antibiotics because of the swimmer's ear. And at that point, I think that might have been enough to, kind of put the microbes away for a little while, put them back into dormant state, because it really wasn't until, again, another few years before she broke. She came home from college that time, and that was really the final point.
Okay, so there's so many other things though I want to unpack with you. So let's one of the things we often ask our guests to do is to go back in time and give the now mom, Professor Ahern, advice. What advice would you have wanted to give to that mother who had her child at the doctor's office after the tick bite? What is the advice, and what is it you'd want that mother to have known that perhaps could have stopped the chronic illness from developing a couple of years later?
What I do tell parents, what I tell everybody is to advocate for, if you have a tick bite and, if you have a known tick bite, advocate for antibiotic treatment. And, generally speaking, that isn't the standard of care. But if you say, there's this concept of informed consent, right? So patients are supposed to be advised of all of their options. And if you invoke that and just say, I understand that antibiotics come with side effects. I also understand that Lyme disease comes with long-term consequences. Weighing both of those, I would prefer the risks that are associated with antibiotics, which is, upset stomach or, and I'm a microbiologist. So I'm not saying that I don't understand the risks of antibiotic therapy too, but given when you weigh those risks and when you're allowed to make that decision, I think, Tony, would you agree if you could take a antibiotic and be done with it as opposed to suffer? Yeah.
Occam's razor. That's what I say. Ticks carry Lyme disease. There's a preponderance of Lyme disease in every state in the United States. And so it's better safe than sorry.
Yeah.
So
Professor Ahern, I've told people to raise hell and pull a Shirley MacLaine from Terms of Endearment, scene, especially when it comes to children, right? I mean, this thing can devastate a child's life. It's been hard enough for me. I was infected when I was 45 years old. I'm 58 now. So in the later stages of life, when things already start to, fall apart, it's been terrible, but you don't want to ruin a child's life.
Mhm.
Right.
Or an adult's life, because in many cases, well, in almost every case where we've done an interview, at least, there is a long gap in time between a tick bite or multiple tick bites and ultimately a chronic illness. And I do want to explore that with you, but there is one of the pieces I want to explore with you, which is on the antibiotic front. What type of antibiotic would you have wanted your child to have, and for how long?
Okay, so can I do a little bit of science on this?
Please.
Okay, so since the days of the recommended antibiotic is doxycycline, right? And that comes from a study that was done quite literally in the 1990s, where they tested 3 antibiotics. One was tetracycline, one was erythromycin, and the other one was a penicillin. I think it was penicillin. And they decided that doxy was the best. However, with all of those drugs, 50% of the people in that study ended up with long-term consequences, right? They all had symptoms that persisted, 50% of them. And of the 3 antibiotics, the reason why they chose doxycycline was because that one was the best. And, unfortunately, the researchers at the time sort of disregarded the long-term symptoms as the aches and pains of daily living, or it's medically unexplained, we don't know what it is. So they said, unless you had a heart condition, or if you had another bullseye rash, or if you had evidence with spirochetes in it, then there wasn't any need for those were considered cures, but they weren't cures. And if you go back and read that paper, they even say in the paper that this is, we understand that 50% of the participants still had symptoms, but we decided to disregard those because it can't possibly be Lyme disease because they were treated with antibiotics. It's so circular, it's ridiculous. So that, the doxy issue, what I can tell you is subsequent research done at Johns Hopkins University and elsewhere have shown that doxycycline is not the best drug to use, because it actually leads to the development of something that in microbiology is referred to as a persister state, which is a form, spirochetes in particular, but other bacteria do this too, where they just, they're threatened. So what do? They, change their form, they go dormant, so the antibiotic can't affect them. And those persister cells are exactly what you think a persister cell would do. They persist, they sit there, and they can reactivate, and in fact they do reactivate. So the studies that were done subsequently kind of indicated that for Lyme disease, drugs like cefoxitin or Ceftin, the cephalosporin antibiotics were far superior. However, there's also the issue of co-infections, and I have to say that when it comes to some of the other microbes that could have been transmitted at the same time, doxycycline is in effect, is more effective for those kinds of infections. So it's kind of the one size fits all approach doesn't work because it's so multifactorial. However, that is the approach. That's what's going to happen. You're going to be told that, okay, here's now they've downsized it from 3 weeks of doxycycline to 10 days for kids, and then 2 weeks for adults, and then that's it. After that point, your insurance company isn't going to pay for anything beyond that. So.
Okay. Again, I'm going to ask you to take your professor hat off for a minute, go back and put your mom's hat on. And now as the mom whose child is now at the doctor's office and she's being treated for swimmer's ear, but she also has other things going on, which you think was a predicate to the chronic illness she suffered a couple of years later, what would you have wanted for that child at that time? Specifically, I have my magic wand here. I'm now taking out the magic wand. I'm sending you back to that time when your child was at the doctor's office. What specifically would you want her to be prescribed so that she wouldn't, in your view, have had to have gone on the chronic portion of her journey?
Okay, so that would have been the tick bite. And what I would have wanted was any antibiotic. I mean, at that point, doxycycline. So again, can I put my hat back on for just one
Okay,
second?
you switch them. Just let us know. What
Really quick. I just want to say, what the science has shown that early treatment, and by early, I'm talking within a week. Okay, so a week to maybe 2 weeks window tops. If the bacteria are treated with antibiotics at that point, and again, doxycycline is the treatment of choice. So even with doxycycline, you have an 85 to 90% probability that you will recover from, that the infection will be caught, that the bacteria will be killed by that antibiotic, and that there will be no further consequences in your life.
Okay, so the earlier the better, right? Earlier intervention
Yes.
is the key. So having all right. So now put the mom's hat back on. As the mom, you wanted any antibiotic that would have been available to be given to your daughter at the moment of the tick bite, and for how long a period of time would you have been on this? Because now you can put your scientist hat back on. We know that the life cycle of the Lyme bacteria is 30 days, right? So do you believe that having a short course of antibiotic for a child, or a longer but still a short course of antibiotic for an adult, is going to be adequate when we know the life cycle of the bacteria, as at least what we call the Lyme bacteria? And I do want to talk to you about Lyme disease and the definition, but do you think that would be enough time when we know the life cycle is more than a month?
Okay, so by life cycle, what you're talking about is the ability of the bacteria to make new bacterial cells. Okay, so that's
Correct.
That's microbial, that's how they reproduce.
Correct.
So the point being, it may take them up to a month to do that, but if that process is disrupted at any point, then they're not able to do that.
Right.
So regardless of the fact that it takes them a month to go through the whole process and make new spirochetes, if you disrupt their ability to do that during that process, they're not going to be able to do that. So I don't necessarily agree that longer is better. Not for early treatment anyway, because really we're talking about different diseases. Early disease is different than once they are what we call disseminated and then going on into late. They are different disease states. There's physiological proof of that now. So as long as we're on the topic of early antibiotic treatment, I would say 10 days to 2 weeks is going to be effective if we're talking about, within a week of that tick bite. So, and that, that's not an easy window, because so many people wait for the bullseye rash to appear. That would be my other advice to parents. Do not wait for that rash, because this idea that it shows up in the majority of cases is baloney.
Right.
So Tony, give us your thoughts on antibiotics, and go back to your first tick bite. What would you have wanted, and is Dr. Ahern giving you some more information now that leads you to believe that perhaps you would have had a different opinion about what type of treatment you would want, and for how long a period of time?
I have before I do that, I have a science question. Professor, a few years ago at the scientific conference that focused on Lyme held, there was a protracted discussion about the biofilms. Mm-hmm. And at the time it was suggested that that the bacteria, if the immune system does not deal with Borrelia, and antibiotics are not introduced within the first 3 weeks time period, that the bacteria could form a biofilm that my takeaway, and I probably screwed it up, but my takeaway was that the biofilm it produces is protein based and can appear to be tissue elsewhere in the body. It's like a cloaking device. It pretends to be epithelial tissue for your heart, right, or for your intestines. That it's like a Klingon cloaking device that it's capable of creating, which means that at that point antibiotics are ineffective.
Right, but it does take them quite a while to actually build those. And the idea, so a biofilm is something that many bacteria do, not just Lyme disease. Mm-hmm. And what I want to do is differentiate between the kind of biofilm that other bacteria produce versus the one that spirochetes do. Because what they do first, and there's all sorts of terminology related to this, microcolonies or microaggregates, because having watched them under the microscope, I mean, literally just sat there watching cells do their thing under the microscope for hours and hours and hours. So I know, ridiculous, right? It's like waiting for the water to boil. But nonetheless, I did, just to see what they would do. And I would watch them in this state of coming together, forming these aggregates with their little tails out on the outside. They would grow what I called heads, and then they would drop their tails, and the thing would grow from that point. So the outside, they're recruiting more cells to this structure. And then when it's all done, I mean, the biofilm, I like to think of it as a city. It's kind of a fortress, right? You said a Klingon device, a cloaking device, but it really is. They build it, nutrients come in, waste goes out, they kick out other cells. And something that's interesting about the Borrelia biofilms is that they don't have the same stuff in them as the biofilms that other bacteria produce. So it's like this, they produce chemicals that come from their cells. They drop their cell walls, they use parts of their cell wall to build these structures. They don't have this one chemical called alginate. They don't have a gene for that. So they can't actually make the classic biofilm that Tony is kind of talking about with, it isn't necessarily a cloaking device. It's just a fortress that once it's established, it's next to impossible to actually get rid of them. And then the question is, in that fortress, what are they doing? Are they able to reactivate? Is it the presence of the fortress that causes inflammation? And, we got evidence on all sides here. So it's really hard to say exactly what it is that triggers all that. But ultimately, what starts it is the spirochete, is the presence of the bacteria.
So Dr. let's pause there, because I do want to talk a little bit more about biofilms, but there is this process or the steps we can take before the biofilm forms, right? So if we're going to talk about that piece of it, so you believe that had you had the opportunity, you would have wanted your daughter to be prescribed some form of antibiotics,
Yep.
Which makes sense. That would be a great tool to try to aid your daughter's system with breaking down or reducing the microbe load, so it would be less likely that she would get chronically ill later on. Now, my next question to you is, as someone who lives in a tick endemic community, and I've been bitten by a tick at least 5 times over the course of the last 3 years. Again, we have ticks all over the place. We have dogs, they come in. I've been bitten 5 times in the last 3 years. What is your feeling about repetitive use of antibiotics for people who are consistently being bitten, and what impact do you think that might have on creating antibiotic resistant bacteria if we're going to be taking either doxycycline or some other form of antibiotic every time we get bitten by a tick?
Right. And that's the problem, right? So again, you got to consider the risk versus the reward. So, my daughter was bit just the once, and then we learned from that point on that we check continuously. And, it is true that the longer the tick is attached, the higher the likelihood that the bacteria are spread, are transmitted. But I will say that her tick was not on her it was 12 hours tops. I mean, I know when we found it, and I know that when she went to bed the night before that, it was not there. And we had been at a horse show that day. So I know that sometime during that night, the thing attached to her, and we found it in the morning. So maybe 12 hours. So, but I would say, if you catch those ticks early and you pull them off, the risk goes down significantly. So that would be, thing number one to consider for the antibiotics. But, the problem is not everybody sees the tick. Most people don't know when the thing attached, because they're so good at what they do. You don't even feel them, doing their drilling or anything. And so you don't know how long it's been. And that part would be that's the part where it would sort of be like, well, if you don't know if it's less than 12 hours or 24 hours, maybe we should do it at that point, So it's a very tricky question, because I totally agree with you. We do not want to overuse antibiotics. We have done that already. And the consequences of that are, we're dealing with that now. And, we certainly don't need to do any more of that. But on the other hand, again, Lyme disease sucks.
It does suck. And that's why I'm asking you the question, because I can say just on my personal journey, When I was bitten I've been bitten many times over my life. Having grown up on Long Island, I was bitten by ticks many, many, many times. And thank God my immune system has been healthy and it's been able to manage the microbes that have been spit into me. But when I went to the doctor for the tick bite that I had just before we started this podcast, or about 6 months before we started the podcast, he prescribed me 5 days of doxycycline, which I then took. And then shortly after that, I was bitten by a tick another time. And I decided in that case that I was not going to take the antibiotics again. I was concerned about the repetitive use of the antibiotics. And I used another strategy, an herbal strategy through Rawls MD. And I think that was very effective. Quite frankly, the antimicrobial elements of that, I think, were very effective. So I think there are alternatives, and I just feel much more at peace with using those. And again, just to share with our listeners, because they probably know this, I have actually been on that protocol from that point forward. I've been taking the Restore kit, at least 50% of the Restore kit from that point forward, because I live in a tick endemic community. I'm getting bitten all the time. And quite frankly, another thing I'd like to challenge you on, Dr. Ahern, is whether or not the tick bite that your daughter received that time was necessarily the tick bite that caused her to have the microbe overload that resulted in her becoming chronically ill. Because I think we get bitten all the time, and at least on this podcast, we've calculated that about 80% of the people who have tested positive on the traditional 2-tier test, and we know that is very narrow, but 80% of those people who have tested positive do not recall ever being bitten by a tick. And I think that's because, as you would argue, they're such stealthy little bugs that, they are grabbing us, they are biting us, they are sucking our blood, they are staying on for a long time, and they're leaving us, and we don't know it. And I think it happens time and time and time and time again. And what happens in cases, at least in our experience, where we have a particular tick bite that is in close proximity to the time we become chronically ill, we point to that and say, oh, that's the tick bite. So do you think it's possible your daughter was bitten many times, and then what happened in the one instance where you did find the tick biting her, you guys are connecting that, or you folks are connecting that tick bite to the chronic illness, when in fact it just may have been many tick bites and many microbes being spit into her over the course of a long period of time, and then perhaps there was an immune disrupting event just before she had become chronically ill, and her system got overloaded with all of the microbes that her body had previously been able to manage.
Yeah, that is absolutely true. I mean, do I know that for sure? No, there's no way to know that for sure. I mean, there would be no way, even if she had been tested for Lyme disease at the point of the tick bite, it wouldn't have been positive anyway. So I totally agree that it could have been something else. But what I believe, I'm pretty confident in saying that what I believe happened is that she was given Lyme disease by that tick way back in the day. And I will tell you that secondary to, well, I don't even know if that was secondary. She also has Bartonella. But we didn't know that for, even after she was diagnosed with Lyme disease, the Lyme disease doctor that we took her to didn't mention anything, tested for the other co-infections, but Bartonella wasn't even really on the radar. And I had to ask for that test as well once I started doing a deep dive into that particular bug. And, honestly, that bug is they're both very remarkable. I have incredible respect for them, even though I hate them. It's just like, you ruined my daughter's life, but it's like, I love you. You're so amazing. From a microbial perspective. Yeah. So I don't know if any of that was true, but I believe that the Lyme took out her immune system. I believe that, and I believe this because that's what the science shows, that they are immune system disruptors. And the mechanisms that they use are not that dissimilar from other agents that we know take out the immune system. And that made her susceptible to secondary infections that, like Bartonella was one of them. Epstein-Barr is another one that a lot of people have in the background that leads to fatiguing symptoms. I mean, at this point, they have pretty much decided that Epstein-Barr is the culprit behind MS, multiple sclerosis too. So what we need to do is we need to move away from this model of one germ, one disease, and just say that this is a very complicated thing, and we need to look at all of these different aspects. And we will be, hopefully.
Oh, I'm so excited. You've
Yeah.
just brought me to my next question, and I really want to ask both you and Tony. And I'm going to ask Tony first. Tony, can you please define Lyme disease for me? What is Lyme disease?
A list of explanatives that I cannot say on the air. I can truly understand how, because, you know, while I'm not a research scientist, I did graduate from the College of Engineering, and all of my science concentration was on the human body in particular. And so I think that that actually helped me to some degree be able to navigate the symptoms I had in the beginning. I would.
But you were healthy too, right? I mean, you were uber fit, and you were able to manage all of these bugs for a long time. And you've been, I mean, you're even uber fit now, right? Despite being sick for a long time. So because you were healthy, you were able to manage it.
I was healthy, but I was on my deathbed many times. And I was on my deathbed most recently when I got COVID, in addition to having chronic Lyme. I did not think I would survive that. And so I'm coming off of a major relapse when my mom passed away 4 months ago, and the trauma of that was, you know, caused me to relapse again. I'm going for an IV treatment tomorrow with my the standard protocol that I do, which is the ongoing IV treatments with oral antibiotics when there's a flare. But you asked me a question, and how would I define Lyme disease? Lyme disease is it is a disease caused by a tick bite. It could be caused by flea or mosquito, but we don't know for sure. But it is either one or a collection of nasty diseases, bacterial, that enter your system and devastate your immune system and other parts of your body. It manifests differently in different people. There are neurological forms, there's cardiovascular forms, there are forms that called horrible thing called cardionephritis, where your heart dies in your body. So the short answer to that is that it's a nasty bug, and it also is very difficult to destroy, because there are implications to the destruction of this bacteria. It produces, I think, a neurotoxin upon death, which can cause what's called a Herxheimer reaction. I'm sure plenty of the people on your show have talked about that before. You got to be very careful when you go about killing things. And some of these bugs, and the professor can correct any of my bad science, because I am not a scientist, is
You're
that
doing fine, Tony. You're doing fine.
Babesia, for example, lives within the nucleus of a red blood cell. You can't go about killing red blood cells, right, and expect to survive it. So this is a very interesting disease, and it's a very fascinating topic when you consider how many different kinds of responses there are for patients responding to Lyme. Which makes it even more difficult, because if you look at the Lyme research, as the professor will tell you, that it's in a vacuum. They look at Borrelia, but they don't look at Borrelia and Babesia, Borrelia and Bartonella in combinations, and the impact that it has physiologically on patients.
So, Tony, what's your reaction when folks say that Borrelia burgdorferi and Lyme disease are the same?
What do I say when people?
Because look, I'll share with you. I had another scientist on this podcast, and we were asking the question about what is Lyme disease, right? Because one of the things we've learned through the last couple of years that we've been doing this podcast, and 350 people we've interviewed, is that Lyme disease is really a disease without a definition. We have as many definitions as we have people that come onto this podcast, right? And how are we going to hit the target if we don't have a definition for the target, right? And I had one doctor say to me, Richard, and she called me Richard, Lyme disease is an infection caused by Borrelia burgdorferi. I was like, all right, if you say so, Professor, but I have a very different definition, and so one of the reasons why we find it incumbent upon us to ask the question, what is Lyme disease, of everyone that comes to this podcast, because there's many definitions that we have as we have people, right? So your definition, Tony, went on for a long, long time, right? Because there's so many different elements to this. But I can tell you that if you had given that definition to the doctor we had interviewed, she would have wagged her finger at you and said, Anthony, that is not what Lyme disease is, because that's what she said to me.
And I would have challenged her to name the 33 species of Lyme.
All right. Well,
If you're going to render an opinion,
so
you better know what you're talking about. Professor, is that correct? How many known species are there of Lyme? And even a Japanese strain is showing up in Flagstaff, Arizona, caused an outbreak in 2009 or 6. I don't remember.
So before we get there, though, Tony, let's ask the professor to define Lyme disease.
Wow. All right, so there are many ways to define it. There is the public health definition, there is the medical standard of care definition, there is the patient's approach, there is the microbiological definition. So which would you like me to provide?
Well, I mean, it scares me that there are so many different definitions, right?
Yes.
I have one of the leading professors studying Lyme disease telling me that within the community of people who are studying Lyme disease, there are at least 5 different definitions of Lyme disease.
Well, within the research world, I would say that the definition is an infection that is caused by Borrelia, and it's not necessarily Borrelia burgdorferi, but Borrelia burgdorferi. This is so complicated because they've actually changed the name of Borrelia. Did you guys know that? Do you know that?
I did. No.
So Borrelia is now Borreliella. The kind that causes Lyme disease is Borreliella. Okay. And then there are the strains that come from Europe. And then there are the relapsing fever Borrelia. So what kills me, this is what gets me every time, that if you have relapsing fever Borrelia, like, the one Tony was just talking about, Borrelia miyamotoi, right? That's the one. So that is a relapsing fever Borrelia. So there will be people who will tell you, well, that's not Lyme disease, that's relapsing fever. And I will say, all right, so let me get this straight. It's this basically transmitted by the same kinds of ticks. It has the same course without the bullseye rash, right? So there's no rash associated with this illness. It is a relapsing fever, which means it stays in the bloodstream for a while and actually causes recurring bouts of fevers and illness, and it's very difficult to eradicate. And then when you ask somebody, well, why is this different than Lyme disease? It's like, well, because it's not Lyme disease. I was like, but it's caused by the same genus of bacteria that are spirochetes. They're transmitted by the same ticks, which, by the way, that relapsing fever group isn't supposed to be transmitted by hard-bodied ticks. It's only the soft-bodied ticks. Although they just found another one in Florida, by the way, that is also transmitted by hard-bodied ticks. So, if you ask a doctor that, they will say it is an infection caused by Borrelia burgdorferi, period, right? But it is way beyond that. It is an infection caused by multiple species of Borrelia here and in Europe. And then there's an associated disease called relapsing fever, tick-borne relapsing fever, which is it's basically the same disease, but we can't call it the same disease because it's not the same. It's bizarre. They just keep adding more and more rules to try to explain this disease when we don't need explanations. We need diagnostic tools and we need treatments for whatever the heck it is. Let's stop arguing over whether we should change its name. Let's actually figure this out and help people.
But Professor, how can we hit the target if the target keeps moving, right? I mean, and so let's go back to, I'm going to ask you to put your mom hat back on, right? When your daughter got bitten by the tick, right? You said you wanted to use an antibiotic, right? And you knew that if you use antibiotics sooner rather than later, then the likelihood is that the bacteria would die before it would reproduce and before it would become a systemic disease, right?
Yep.
But we were debating a little about which antibiotic you would want, and you still haven't really given us an answer whether or not doxy would be better, or some other bacteria. I mean, some other antibiotic would be better, and of course it begs the question: well, if it's a broad spectrum disease, or is it better to use a broad spectrum antibiotic, Or if it's a more narrowly defined bacteria, is it better to use a different kind of bacteria, right? So I now have your mom's hat on. You're back in the day, again, I'll bring out the magic wand again. You're now back to the day when your daughter had the tick bite and you went to the doctor's office and you wanted to make sure that she didn't become chronically ill. What antibiotic are you going to use, and why are you going to use that when we have different definitions of this disease? Because I'm going to tell you what our definition is here at Tick Boot Camp. Our definition is it's a polymicrobial, multisystemic, chronic infectious disease. That's what Lyme disease is in our view. It isn't one bacteria, it's many bacteria. It's not one party system, it's many systems, and it is a chronic disease, not an acute illness, right? And I think if we all come together around that definition, then we could start moving towards hitting that target. But if we continue to have all of these different, if we continue to have all of these different definitions, we're never going to get to the point where we can come up with tests, and we're never going to get to the point where we can come up with a treatment that's going to work.
We need to treat them as separate diseases. There are, so in other words, what you just said, going back with my mom, I'm wearing my mom hat is on at this moment.
Sure.
At that point, Lyme disease was explained to me, my fear that it could be Lyme disease, because, we went through all that, was with the tick. It was, the doctor said, okay, that's what it is. It's a disease. It's an infection that's transmitted by ticks. It's caused by Borrelia burgdorferi. And if she gets symptoms, then this is the best antibiotic for that. Okay, so when you go at that point, and we're talking about 2009 here, all right, so this has been a while. When you go look up stuff, where do I go look up on information? I didn't go to the internet. I went to the CDC. Right. I went to the NIH. Right. I went to the scientific literature. Right. And guess what? This is what I was finding. So it's like, okay, we'll wait and watch for this rash, and if it doesn't happen, it isn't Lyme disease. So that's the medical definition, and the medical definition is the acute form, the EM rash. That's it. But that is a thing that does happen to people.
Now let's talk about the medical definition, because I want to get your reaction to this as well, Tony. Right? Because the reason that was the medical definition is because there were many other people who were either making observations in the field as clinicians, or there were people who were doing research that were not able to gain access to the medical journals to present a definition of Lyme disease other than the one that you found when you were researching through the CDC, the NIH, and the scholarly journals, right? So we had many clinical observations that were beginning in the 70s here on Long Island with some brilliant researchers, and they couldn't get access to the medical journals. So now what happens when mom, again, I wanted you to be my mom if I'm living in a tick endemic community. I want somebody who has the ability to get that information so that I can be treated properly. But guess what? Despite being a professor, despite being this genius that you are, despite being the person who has all this information, you go to all the sources that you would go to as a scholar, and guess what?
They were wrong.
And they were wrong despite there being other sources available, because the people who had their hands on the gates that allowed these research papers to be published the gatekeepers weren't allowing the alternative definitions, which have now borne out to be true 40 years later, 50 years later, that should have been available to somebody like you. So at least you would have had the alternative options as a parent to decide how you were going to evaluate your daughter's illness.
That is correct. That is absolutely correct.
So,
and I to this moment, I'm still pretty outraged about that, because it wasn't like the science wasn't there, because throughout, from 1977 until, 1995, when you read the scientific literature, the historical scientific literature, and you look at, it was like they had it. It was a long-term chronic illness. There was neurological Lyme. There was, some people didn't recover. Antibiotics didn't treat anybody. It was congenitally transmitted. All of those things were there. And then in 1996, it ended pretty much. And it started with, this alleged consensus meeting where they try to decide what would be the best diagnostic criteria for surveillance purposes. And ultimately that ended up being cemented as how they diagnosed the disease. And then from there, which, I don't know if you even want to talk about that, but from there we move on to the, the issues with the vaccine, the first vaccine. And all of that actually played into cementing in place this idea that no, we have to have a way to define Lyme disease. So we're going to define it as a bullseye rash and or positive serological test results, even though now, and they knew it then. But now, the evidence is so strong that those are like the two worst things you could possibly use for diagnostic criteria. So,
but Tony, what happened here was, of course, Lyme disease was named Lyme disease as a result of two mothers jumping up and down about their children getting sick in Lyme and Old Lyme, Connecticut, right? One of whom was a former World Health Organization employee, right? So they're jumping up and down. They're really upset that they see all of these children in their community suffering with the same symptoms and no definition, right? So what happens? The Connecticut Department of Health goes to Yale University, an Ivy League college, and they assign one of the young rheumatologists to do some research to determine why all of these children are suffering from these rheumatological symptoms, right? And they name this Lyme disease. They don't know why they all have it. They do see some ideas about why this cluster is developing, but they ultimately name it Lyme disease, right, Tony? And then what happens is that scientist, that researcher, the guy who named it Lyme disease, then becomes the gatekeeper on all of the boards of the scholarly journals that are going to be deciding whether or not they're going to publish alternative definitions and alternative findings on this. One of those people who's doing research is Dr. Alan McDonald, who we've interviewed on this podcast several times. And when he presents a paper that suggests that it's polymicrobial, when he presents another paper that definitively demonstrates that Lyme disease could be congenitally transmitted, he calls it the dead baby studies. In the early 1980s, he's accused of fraud. He's accused of doctoring the data, and his papers never get published despite them being presented at the conference, because this same doctor who defined Lyme disease as a single bacteria, who named the disease, wouldn't allow it to be published. So now we have Dr. Ahern, whose daughter gets sick the way you did, Tony, getting her life ruined the way your life was being ruined, and the alternative information was available in the 1980s, but the gatekeepers wouldn't let it be released. What's your reaction to that, Tony?
My reaction?
Yeah.
Well, in 1989, I was diagnosed after a two spinal taps with lowland swamp fever caused by an undefined biological cause agent. That was my diagnosis in 1989, Professor.
So aliens, in other words.
Right.
Yeah.
So there's an entire body of evidence to suggest that something other than honest research is going on outside of the research that's being done by individuals like the professor that's on with us today. I don't know that. I don't know it, and honestly, I want to get well, and I'm more interested in knowing what the current research is, and how close are we to a 100% accurate diagnostic tool that will also help those suffering from chronic Lyme, because I continue to test positive for the antibodies, and they light up, and yet my doctor persists in telling me that that's not the root cause of any of my issues, right? So the only response I have to what you just said is outrage, and outrage is not good for my health. So I'm going to pass this the answer along to the professor.
I appreciate it. So let's take the next step, Professor. And the next step is what we have this relationship in the medical community between those of you who are researchers and those people who have the right to treat us clinically, right? And the way the relationship is supposed to work is you folks do the research. After you have your findings, the findings, if they are replicated by others in your community and become generally accepted among the community of people who are doing the researchers, those research findings then become the protocols that the clinicians are supposed to be following. And when the clinicians follow those protocols, they're safe, except they're only supposed to be stepping outside of those protocols when they, through their clinical experience and training, are treating an outlier. And when they're treating an outlier, they can step outside of the protocols that have been generally accepted by people in your community, the research community. But other than those rare instances where somebody is outside of the bell-shaped curve that you're studying, and they're an outlier, they have to be treated within the confines of the generally accepted medical practices that are defined by folks like you. But here's the problem, right? The clinicians are seeing something on the ground that they know is not consistent with the research findings that are available to you, because the people who are at the gate are not allowing the alternative research to be made available. So what is a clinician to do? The clinician knows that the research is not accurate. They know that your daughter is sick and there's something they can do about it, but they also know that they treat your daughter outside of those generally accepted medical practices that have been generated by people like you and the gatekeepers who are allowing those things to be published. What do they do? What's a clinician to do?
Well, my hope is that we can put all of this behind us shortly, because there will be a way to determine whether or not somebody actually does have Lyme disease or not. I mean, and what I'm talking about, so I had a very interesting conversation with a pediatric infectious disease doc, and that person provided basically said, look, we need tools. We understand this is a problem, but we don't have anything in our arsenals that allow us to help. We don't have an accurate diagnostic test. How are we supposed to make a diagnosis? Yes or no? You have Lyme disease or you don't. We don't, whether or not antibiotics are effective at various stages, that, we don't really have good guidance on that yet. And then there's no therapeutic. So for the patient, the chronic patient, at this moment, antibiotics can help. I mean, it certainly keeps some people functional, but it's not a treatment. It doesn't get rid of the spirochete, so the symptoms will come back and come back. But the point being, it improves people's health for their overall well-being for a while. Shouldn't that be good? I mean, that this is why they give drugs to immune suppressing drugs to people with autoimmune diseases, right? To help them have a quality of life. So why shouldn't we be using antibiotics to help people have an improved quality of life? I mean, it's not going to cure them. Neither are the steroids or the immunotherapies that they're giving to autoimmune disease. It's not going to cure them, but it can help them stay better. But the infectious disease doc was saying, we don't know what the appropriate treatments are. We need treatments for the chronic patients, whether or not it's antibiotics. Probably isn't. Probably there are other things. We should look for immunotherapies. We should look for monoclonal antibodies that could be treatment for this disease. And just as a preview, we're moving into that realm. Once we have the diagnostic, we're moving into therapeutics, because those are the two things that really need to be addressed in this disease.
See, the problem is that you folks in the research community are deliberate and slow. And I want you to be deliberate and slow, but you are really slow.
We're 20 years ahead of them, Rich.
All right, well, but you may be, but unfortunately, being 20 years ahead of your fellow researchers is not putting us in a position where that's becoming the standard of care. And because it's not becoming the standard of care, we have people like Tony who are really sick.
Yes.
And people like Tony who are really sick are going to their doctors, and their doctors are afraid to treat them despite having the ability to clinically diagnose him and treat him, because what happens is, and we're going to get into insurance companies and pharmaceutical companies in a moment. You've already teased that, Professor. So we're going to get there in a minute. But what we have, of course, is we have doctors who have adequate training to clinically diagnose and treat their patients. But if they do clinically and diagnose and treat their patients outside of the generally accepted medical practices that are defined in essentially statute by the medical journals, they're in a position where they could lose their license, right?
Yeah, and in fact, in New York State, that it has happened. In this particular state is, back in the 90s when, the first set of physicians were seeing all these cases and they were treating with antibiotics. Having talked to many of these doctors, they were reported to the Office of Professional Medical Conduct, which is part of New York State. And then once you are reported, the office has to go, basically do a review of everything. And that costs, the physicians that this happened to, I know had to spend thousands and thousands of dollars to defend their medical license for not doing anything wrong other than trying to help their patients. And, several physicians that I know have had to go through this multiple times, not just once. And so I was part of a group back in the 2014, and actually this bill was signed into law in 2015, which protected doctors from punitive review by the Office of Professional Medical Conduct. That law is still in the books today. And I have to tell people they can invoke that because, the idea that a patient who was displeased with the way they were treated, insurance companies that didn't want to pay a bill for IV antibiotics could report these physicians to the Office of Professional Medical Conduct, which then were required to do the review. But in the meantime, the physician would have to hire a lawyer, would have to spend not thousands of dollars, tens of thousands of dollars to defend their medical license. And, a lot of them are not able to do that or willing to do that. And so the alternative is, fine, I'm not going to see Lyme disease patients. And that's why we have an issue with access to care. There's not that many physicians that will, work with chronic Lyme disease patients. They're willing to see early Lyme cases because antibiotics are really not as controversial at that stage. It's just in the later stages. But the point is, those physicians are few and far between, even here in New York State. And, we are a highly endemic state and perhaps the leader. Yay, we're number one. But so there should be more specialty physicians that are able to deal with patients that have this chronic form of the illness. And they're aware, but they again feel they don't have the tools. They don't have the diagnostic tool. They don't have any treatments that they feel comfortable prescribing. But what physicians should know is that in New York State, that law exists, that law is on the books, and that they are protected from Office of Professional Medical Conduct review to some extent, at least.
Well,
it's not like they can get away with anything, but they are, just because they see Lyme disease patients is not a good enough reason to.
Well, but the problem is, Dr. Ahern, is that one of the doctors we interviewed on this podcast is Dr. Joseph Burrascano.
Yes,
who is treating Lyme disease patients in the late 70s and the early 80s.
Yeah, he was one of the first. Mm-hmm.
He wrote this brilliant guide on how to treat patients with chronic Lyme disease in the early 1980s.
Yeah,
but he stopped treating patients with Lyme disease. And why? Because the medical board came in, investigated him, and forced him to be supervised by another doctor for 2 years, even though if you look at the guide today, and we've now looked at it in 2023, it's right on. If we use his standard of care that he defined in the 1980s, I can tell you right now, many, if not most of the people who are sick from Lyme disease wouldn't be sick today. But what happened? They sued him. He had to spend $1 million in the 1980s. We're not talking about thousands, I don't think $10,000, $1 million in the early 1980s in order to be able to keep his license. And although he kept his license, he had to be supervised by another doctor, and then he stopped treating Lyme patients. Now, what did that do to Long Island, where I am, which is probably the most tick endemic portion of New York State, right? We have no Lyme literate doctors. We have no Lyme specialists. We have zero. I recently had a friend who was bitten by a tick, and he said to me, "Can you help me find a Lyme literate doctor to treat me so that I don't get sick?" And I went on, I did research to find a Lyme literate doctor on Long Island, and we couldn't find one, not one. So what's happened is, we have these research standards, which are wonderful. We should have generally accepted medical practices that are based on research that has been replicated and accepted by the people in the community who are doing the research that you're doing, Dr. Ahern, right? We should be bringing those standards down so that clinicians have a guide that they can follow in order to be able to treat people. But then we get into a place where we have a politicized system with gatekeepers who are stopping research from being published. And we have clinicians on the ground who want to treat patients, but when they do treat patients, they find themselves in a position like Dr. Burrascano, despite being a brilliant guy who was educated in one of the top medical schools in the country and was doing great work. He was punished and ultimately run out of town, literally run out of town, right? So now we have a lot of researchers who again, put your research hat back on, who are very critical of clinicians who are putting people on the antibiotic loop, or at least that's what we call it here at Tick Boot Camp, where you're on antibiotics, and then they come off and then you're on, and they come off and you're on, and you come off and you come on, and you come on. So we call that the antibiotic loop, right? But what alternative do we have when we don't have diagnostic tools and we don't have treatment tools and we don't have immunotherapy? Right. What's the alternative for these people?
There is no alternative. And that is what really is there is no, so it's basically either you have to follow these rules or too bad for you, you're screwed. Right. And that is the part that, I mean, that's why we're here, right? It's not about the lucky winners of the bullseye rash and the people who get treated early. It is about the chronic patients who have been, basically left on the doorstep. There's just nothing to do other than try to figure it out yourself. And then if you try to figure it out yourself, you're called all kinds of names. It's like, oh, well, that's not right. And it's witchcraft and it's this and it's that. It's like, yeah, no, I mean, there's good science behind a lot of these things. And I have to say that at this stage, the Infectious Disease Society of America standard of care is the dominating one, just because of the way medicine has been compartmentalized, and infectious disease specialists are thought to be able to know everything there is about infectious diseases when, in fact, when you look at what they do, it's like, all right, well, here's the disease on this list, and that's the antibiotic you're supposed to prescribe. So that's what we're going to be treating. But that all hinges on having an accurate diagnosis. So if you are the, you are the 4 out of 5 bands on the IgG Western blot, you are not going to, the infectious disease doc is going to say, no, that's not Lyme disease. We're not treating it with the antibiotics. Let's start the steroids or something along those lines. So the International Lyme and Associated Diseases Society has a standard of care. They published a paper. It was peer reviewed. It was actually, when they had this, the clearinghouse, the guidelines clearinghouse, it was part of the guidelines clearinghouse. And, when I read things about those guidelines, about how it's, that they're not science-based, I said, and I've said this out loud on many occasions, yes, they are. Go read the references, look at the paper. It's more patient-focused because they actually include patient perspectives in all of that. And there's no quackery involved in it. They're basically saying, treat your patient and see if it helps. Well, I mean, they'll do this for other diseases. This is the part that I don't get. If you have cancer, you're given one chemotherapy drug after another, and they're all toxic. I mean, they're all doing damage. So, but that's perfectly fine because their life is at stake. Well, Lyme disease patients' lives are at stake also.
Well, is that really what it is, Dr. Ahern, or is it, and I'm going to ask you 2 more questions, and I know Tony has a lot he wants to geek out with you on, but have we sort of created these tunnels for politically aggressive groups? For example, have we created a tunnel for cancer because we know you're going to die anyway, right? So we have a tunnel where aggressive, advocates have allowed for this kind of trial and error with people with cancer, and we sort of maybe have another tunnel for AIDS where we had people dying in a very short period of time, and people organized and they ultimately created a tunnel there. But for every other disease, if you don't follow the medically accepted guidelines that have been created by researchers like you, doctors are putting themselves in a position where they're going to have their license pulled or at least threatened, right? And they're not allowed to be treated clinically. So I guess the reaction I'm trying to ask for you as a researcher who's on the other side of the team is do you think we should really be putting these kinds of handcuffs on clinicians or should we be giving clinicians the freedom, not just in sort of tunneled areas like cancer and AIDS and maybe now Lyme disease, but really let clinicians do their job? And, if they believe that they have an outlier, let them treat an outlier, and let's not be critical of clinicians who are doing that kind of work, because I can tell you, most of the other researchers that we've interviewed have been like wagging their finger at clinicians, like, for example, like Dr. Horowitz is one of the most brilliant people we've ever interviewed. And we had one, brilliant, researcher who was like, he's doing terrible things and he shouldn't be treating people clinically, and he should be using these antibiotics because we don't have enough research to support the, the double dapsone protocol, right? I mean, this guy was, all but calling Horowitz a quack. Because he's on the other side of the divide, which is on the research side. But, I can't tell you people who are dying to get into Horowitz's practice because of the successes that he's having. So give me your perspective as a researcher about your colleagues who are wagging fingers at the clinicians for treating people with the clinical observations that they're making.
Well, first of all, Rich Horowitz has published several papers, and they're well-done papers that have basically shown the efficacy of his treatment. Now, it doesn't work for everybody, and it is a tough treatment, but I would argue that the dapsone protocol is, he borrowed that from tuberculosis. So, so it's okay for tuberculosis patients to go through this, but it's not okay for Lyme disease patients to go through this. I mean, and honestly, the diagnostic criteria for tuberculosis is almost as ridiculous as it is for Lyme disease. I don't know if you
but he's a clinician. He's not coming from the research world, and because
but he's publishing, and he's publishing using the scientific method. So in other words, he has proof that what he is doing is making a difference. Not, like I said, his efficacy rate, I think, is about 50%, right? But that's 50%. That's 50% more people that now have their lives back that didn't before. Shouldn't everybody have that kind of access? And quite honestly, you're talking about giving tools to clinicians, but I would say that what needs to happen is patients need to stand up and exert, there needs to be a greater patient rights thing where it's sort of like, let me make the decision. You tell me, all right, so you take this antibiotic and it might cause this, that. Let the patient decide. I want to try that because it might make a difference in my life, or it might not. And if it doesn't, then we'll try something else. But that should be the patient's choice. That is the whole thing behind, the right to informed consent. So if you're going to do, and, the AMA has a whole blurb on, your patients have this right. So it's like, yeah, we have the right, but you try to exert that right and you get a lot of pushback from that. So you just, and a lot of people don't, I'm not one of those people, but a lot of people don't, if the doctor says something, it's like, oh, the doctor said, so that's the way, I'm going to do it that way. And you mentioned Dr. Burrascano. When we were still trying to work with our primary care physician, and I found Dr. Burrascano's guidelines, I brought them to him and I said, this is I'm here to advocate for this standard of care. To my doctor's great credit, he read it and went through it, and he was willing to try, and at that point, really the big thing was, upping the dose of doxycycline and doing it for a longer period of time. Right. And, what was wrong with that? Nothing. And,
the other thing, one of the things that Dr. McDonald told us is when his wife was diagnosed with Lyme disease, actually Burrascano had used minocycline.
yes.
And what happened was that one of the challenges that Burrascano had to deal with was that when he was going through that process with trying to defend his medical license, is that her liver counts had gone high, and as a result, he had to back down on the minocycline, right? And he wasn't allowed to use it anymore, and that's why he was going through the. But as it turns out, you had listed the 3 different drugs that are now being researched, and which of these drugs would be most effective at the acute phase, right? And what Dr. McDonald has subsequently learned is that the Lyme bacteria very aggressively invades your liver as a vehicle for reducing your capacity to detox. And one of the reasons he now knows 40 years later that his wife's liver counts were being altered by the minocycline, which is much more effective at dealing with the bacteria in the liver, is because it was killing the bacteria in her liver, which is trying to shut down a liver so that she couldn't detox as part of its effort to destroy the immune system, right? So Burescanner was on that again in the 70s and the 80s and and it was shut down. And now we're looking at we keep seeing this pattern of clinicians making observations in the field that are having success and being taken away because there isn't adequate research to support what they're seeing in the wild. And because there isn't adequate research, then we can't use it, right? I'm going to ask you one more question. I'm going to let Tony geek out with you. And that is one of the biggest concerns that I have about the research in your community, despite us now having some enlightened people like you who are personally invested in stepping outside of the box because you've had your own personal experience with your child having dealt with these chronic issues. Most of the research dollars are going to research one strain of one bacteria, right? That's what we're finding. So
what money there is.
Well, okay. Well, but we're looking at one thing, Tony, right? We're looking at one strain of one bacteria. And you earlier pointed out that all of these different strains are going to have different presentations. And why are we not seeing a bullseye rash in some cases? Well, maybe it's the Japanese form of the Japanese strain, or maybe it's the European strain, or maybe it's birds fly everywhere, right? So I'm not really excited about where we're going with the research, especially since I've argued to you that we define it as a polymicrobial infection. If we're only looking at one strain of one bacteria, how long is it going to take before we get to a place where we can have diagnostic tools that will allow us to really define what's going on with people? And how long after that is it going to take us to be able to get to the point where we can now start to work on the immunotherapies that we're going to need to use, because we now have a test that we're going to define, right? And should we be as patients, should we be concerned about that?
As patients, we should be concerned about a lot of things. So going back to the working with just one species, and part of that is because these bacteria. So as doing microbiology research that leads to medical research, one of the things that we rely on is being able to grow the bacteria outside of the host, outside of the human body, and then we can do things with it, right? We can try antibiotics against it. We can, every other disease, every other infectious disease that we can do this with has been done that way. And there are not that many strains of Borrelia that are culturable, right? So they are alive, but we can't quite get them to stay alive in an easy way, right? This is why culture-based tests are not necessarily going to be the approach, because sometimes they don't grow, sometimes they do grow, sometimes they grow and stop, and then they start growing again. This is all part of the nature of the bacteria. So I'm going to give a shout out to the bacteria for being part of the problem, with the research that we have with all this. So that part, it's not that there aren't good ideas. Number one, it's a hard thing to do. Although now we have really great molecular tools. And so we're less dependent on growing the bacteria than we have ever been in history. So we do have that going for us, looking ahead to the future. But, the issue with research is funding, and the fact that it has not been prioritized by NIH or HHS for various reasons, because they are being, they follow what they view to be the expert opinion, which is really the Infectious Disease Society of America view of this disease. So that there hasn't been a whole lot of interest in funding these diseases, but on that side. And then what I have to say is over the past 10 years, and this would include Focus on Lyme, it's just, all right, so if the federal government isn't going to fund research, then we, the patients, need to step up and fund it, find ways to do it. And so I would say over the past 10 years, when I first got into this game, there was LymeDisease.org and there was the LDA, Lyme Disease Association. And from those two resources, I learned so much. And then since then, a bunch of other organizations, Project Lyme, Global Lyme Alliance, although Global Lyme Alliance had been in the picture for a while, before that. Project Lyme, Bay Area Lyme, for example, all of these came about in the past 12 years. They're raising funds like crazy. They're funding research. A lot of the best research has been funded by these organizations privately. Yep. And, that does have an impact on public funding for research. So in other words, now we have all these results that we can use to request funding for other research. And that, so it's happening, and it's not happening fast enough, but it is certainly, it's rolling. We're rolling on that particular aspect of it. And another thing, I want to give a shout out to Center for Lyme Action, who is an advocacy organization that started 3 years ago, but they're a lobbying. I mean, basically, that's what we needed, was a group to go lobby. I mean, we were fighting against medical lobbies who are basically saying, fund this, fund that, don't fund that. That's not important.
Right.
And now that we have a voice, funding it has increased a lot, or over $100,000, which, sounds like $100 million. Sorry. It sounds like, that's a real ton. But when you compare it to other diseases, it actually isn't so much money, but we're getting there, So I'm looking at where we are now compared to where we were 10 years ago. And although the progress has been slow, I think that, we're right at the top of the hill. The stone, the big rock is like right there. And it just needs a little more force to get it over the hill. And then it's going to start sliding downhill, and we'll see some real progress.
So let's circle back to the question. I'm sorry.
Sorry, Rich.
So I wanted to circle back to where Tony had taken you, so I can now hand you off to him, because he has a whole bunch of questions to geek out with you on, and that is that we had left the persister state, and we were talking about the challenges that are associated with not having the capacity to engage in earlier intervention. So Tony, do you want to take us back to that and talk about the challenges that come along with our inability to intervene early, either because we don't find a tick bite, we don't have doctors who understand what steps should be taken, we don't have a clean set of standards that doctors feel comfortable with when diagnosing and ultimately prescribing medications. Now we get to this phase where now this bacteria has taken off, they start to colonize, they start to form groups with each other and other types of bacteria. And now that puts us in this position where we have this biofilm that becomes very difficult for our immune system to deal with, and we have all kinds of things going on inside that biofilm. So Tony, one of the things we had talked about on your episode is what starts to happen, of course, within the biofilm is that these different bacteria start to exchange DNA, and they start to reform, and they start to do all kinds of things within that biofilm. So maybe we can, Dr. Ahern, you could take us there. What's happening inside that biofilm, and why is it more than just protecting the bacteria that's a concern, but the exchange of proteins and all kinds of things that are going on there that are like reforming the very bacteria that our immune system should have a code to kill, but then doesn't when it reforms?
Okay, so I'll and then Tony, pop in when you want to, okay? But so what I was saying about the biofilm of Borrelia, so there's what we understand about biofilms comes from our experience with other bacteria, mostly that are easy to grow, easy to watch the biofilm, easy to, again, going back to that, you can grow them outside of a host, you can grow them in culture. So we know a lot of information about those bacteria, but in terms of what the Borrelia biofilm is, there really has not been a huge amount of information. So Dr. Eva Sapi has done a lot of work with that, but nonetheless, it's just one lab, and it's hard to characterize what's actually in those biofilms. And as a result, I know what the definition of a biofilm is in terms of looking at Pseudomonas aeruginosa. That's another bacteria that is well known for its ability to produce biofilms. But when you compare the classic biofilm with what Borrelia is doing, there are huge differences there. And I'm not surprised at that, honestly, because they're not the same bacteria. They live life differently, very differently. So I don't think you can use the classic biofilm model for Lyme disease. What the bacteria are, they will establish themselves in tissues, they form colonies, they bind to it's a protein within the collagen fibers, right? So it binds their decorin binding protein, and it binds, and it will start to establish these microcolonies, and they will grow. But once it's in tissue, we don't really know a heck of a lot about what is going on beyond that. So there's some research now saying that, the bacteria in the biofilm, as they drop their cell walls, and they have this chemical called peptidoglycan, which is part of the cell wall of the bacteria. And, that's part of the matrix of biofilms for many bacteria. It's part of the cement that holds the fortress together. And so there's a research team that is basically, indicating that they have found that the peptidoglycan itself, this protein that the bacteria leave behind, if you will, so whether or not it's the dead bacteria that are leaving behind these body parts, or if it's part of the building material within their biofilms, it's there one way or the other. And they have really good evidence that it's the peptide, it's that's driving this, these extreme flares of inflammation, which, let's say, that's the hallmark of Lyme disease, is just, inflammatory, escalating inflammation, and all over the place, multisystemically. So in other words, we need more research. This is an area where it would be good to build on what Dr. Sapi has done, and do a deeper dive into, what actually is going on within those structures within tissues. But to do that, you have to have tissues. You have to have a tissue collection. You have to have, biorepositories, and we lack that in this field too. So again, that's also changing thanks to Bay Area Lyme. They have started not just the blood biorepository, but they also have a tissue biorepository now, although there's not a ton of samples in there. And I also have to say Columbia is doing this too. And Dr. Monica Embers at Tulane University is working with Columbia University, mostly brain tissues, where the brain tissue from people who have died with chronic Lyme has been shipped down there. And she's found spirochetes in there. And that is disturbing to me because, my kid and Tony, right, is like, are they in there? Are they not? And if they are, what are they doing? And I just like to hope that if you keep doing the right things, you can keep them under control, or maybe they're not there at all. I don't know. But the fact that, they are able to physically find using pathological methods. So in other words, this is direct detection. We're not guessing here. There they are. So that is obviously part of the pathology involved with that. And we need more studies like that. We're talking about 5 brains, right? So, we need a bigger sample size before that's going to get accepted in the medical world as proof that all cases are the result of this, right? So there's a long ways, we've made progress. There's still a long way to go, but we need to do what we did with HIV, and really do a deep dive into that and just say, holy cow, this is impacting a huge number of people and it's ruining their lives. I mean, granted, AIDS was, at one point a lethal disease, right? You were going to die. Not that Lyme doesn't make you wish you were dead, but nonetheless, we need that kind of energy. We need that kind of investment in time and resources in this disease as well.
Right. There's sort of a formula for the trajectory of these things, and it includes the scientific approach, education, advocacy, but then activism, which causes change, and which all that equals public policy changes, right? But that activism part is missing. And that activism part is missing because we don't have enough smoking guns. If we don't have enough brains being, for every Alzheimer patient, every MS patient, every person diagnosed with an autoimmune disease, that brain tissue should be examined for the presence of spirochetes. And we need, in order for us, and AIDS had a direct cause. You got AIDS, you died. So ACT UP was able to influence public change because it filled that activism role. We don't have that right now, and we need it. So I'm heartened by some of the things I've heard, and I have some research questions for you that I'm burning to ask you whenever it's my turn.
It's your turn.
Is it my turn? Woo! Okay. So the first, before we get into the research, this is a personal indulgence. What is the connection to iron, And there are consistent increases in ferritin levels for patients who have chronic Lyme disease. I've heard that Borrelia uses iron for cellular respiration, and I've heard from others that that's wrong. It uses glycogen or glucose, just like we do. But how does the Borrelia bacteria eat?
So that's a really cool question. And they don't, so to take food and turn it into energy, there are many different sources, right? But one thing that Borrelia does not have is the ability to, they don't have the ability to do respiration. And that means electron transport system. They don't have any of the enzymes to do that. They basically live on fermentation. So in other words, they have to take, and when I say sugars, I don't want you to, there's actually many, many different forms of this, but they only have the ability to go through like this very first part of the respiratory process to make ATP. And they don't really make a ton of it, which is why it takes them so long to grow, because the energy conversion process is not the most efficient. The ways to do this, it's not efficient, but it also keeps you under the radar. So it's kind of a brilliant, trade-off, if you will. So they grow slow, but our immune system is always on the lookout for these things. And if they, kind of creeping along, it's another one of the way that they evade detection is to not be super active. So, but that, I don't know if that answers your question, but they don't do respiration. So, and the idea of iron and that I think a lot of that has more to do with the impacts on your bone marrow and being able to produce red blood cells and things along those lines. That's probably where the iron issues are coming from. And then when anybody says iron, I always think about Bartonella. I think about Babesia because they actually do infect red blood cells and ultimately cause their destruction. So, there's that part as well to add, just to make it more complicated, because, why would we want this to be simple?
Right. In my line of work, it's my job to identify patterns and to exploit those patterns for their best uses, right? And so we see patterns of behavior in consumer behavior, in the way businesses talk to other businesses. So like there are patterns all over the place that we in marketing and branding identify. So I see so many Lyme patients who have increased albumin levels, they have increased ferritin levels. All of these things are pointing to this action going on in the liver, right? And liver damage that ensues. As a result, we're already in a compromised position, and now we're taking antibiotics and pain relievers and things that have a high impact on our livers. So I'm interested to see where that research goes, but I want to ask you some personal questions for our viewers and listeners, so they get to know you and your work a little bit better. But the first question I have for you is, how is your daughter doing?
Well, thank you for asking that question. So, my daughter, really should ask her that question, but, she views herself as having emerged from the other side. That doesn't mean that she doesn't have times where she crashes. But her crashes are not like they used to be. Her crashes are, I have to go to bed, it's 8 o'clock,
Right.
And then she'll wake up the next morning and be able to carry on. She is doing a lot better. And if we used to I used to ask her on a daily basis, okay, what's your grade today? And she'd say, oh, it's an 80%,
Right.
And, we went from about a 20% to 60, 65, 70. And then now she's like, I put myself I'm in the upper 90s. She really is feeling pretty well. And at this point, she's in charge of her own care, and she does a lot. She really does do a lot of things in terms of dietary. She's just really cautious about everything, which I'm sure you are too, and avoids inflammation, anything that could possibly be inflammatory. She stays away from, and so she's doing pretty well.
Great. I'm very glad to hear that.
Yeah.
The next question I have for you is, can you summarize the Lyme research that you've performed to date?
Well, so and this is going to focus on Lyme. I assume that's the question you're asking specifically, right?
In general, the Lyme research that you've done to date, and how did that lead you to focus on Lyme?
Well, focus on Lyme happened through Dr. Horowitz, actually, because Tammy Crawford, who is my partner in Lyme, her daughter Jessica, who happens to be just about the same age as my daughter, also an athlete. Also, I mean, when we talk about our stories, it's just like, oh my, they're the same. It's pretty much the same. So Tammy actually, because she in Arizona, doctors it's just like Lyme disease. What the heck is that? They just don't really think about it because Arizona is not thought to be an endemic state, and nobody gets it in Arizona, but that's not true. When she finally did get diagnosed with Lyme disease, because she went through months of trying to figure out what was wrong with Jessica, with her daughter. They, immediately started, once the Lyme disease diagnosis occurred, she immediately went to the internet and found what the Lyme specialists were, and she found Dr. Horowitz, Rich Horowitz. So they made an appointment. Actually, she hunted him down at an ILADS conference. And at that point, he was sort of at the edge of not taking any new patients, but she talked him into it. So they flew from New York, or from Arizona to New York, landed in a snowstorm. How classic is that for New York? And they were basically stuck there for a week. They stay there for a week. And so she started talking with some of the people that were in Rich Horowitz's office. And she said, so then she had this idea that she wanted to start an organization. I mean, this is what we do, right? It's just like, we got to change this. We're going to start a 501c3. And she had that idea. And so she asked one of the people working in Dr. Horowitz's office if she knew any microbiologists. And so I get this call from Phyllis Freeman, who is in Dr. Horowitz's office, saying, okay, so I might have given your name and address out to somebody from Arizona. And I was like, okay, I'll talk to her, just whatever I can do to help. And then as soon as we started talking and we saw the parallels to that, Focus on Lyme was born, and that was that. And we both realized that, what we needed first was the other advocacy organizations were doing a good job, with awareness and education and even political advocacy, because that's really what I was doing at that point. But we needed to focus on the things that were going to make a difference in people's lives. And that's where we moved into the research leading to an accurate diagnostic test. I mean, that has been our focus pretty much since we came together. The other focus, of course, is to take what we're learning from our diagnostic research and turning it into a therapeutic. And I think there's hope for that, honestly, a targeted therapeutic for, that would address not just the infection, but also some of the other, immune system issues and other things that go along with that. So my research, once my daughter was diagnosed, I started doing research on what are ways to do this? So I grew the bacteria in my laboratory. I started with different antibiotics, trying to figure out what would be the best approach. My daughter actually very successfully used a Rife machine. I don't know if you're familiar with a Rife machine, and the story about how we came to that was another one of these weird coincidences. But I wanted to find out if this Rife machine actually worked. And at that time, there was a person working at Skidmore College, which is a local college here in Saratoga Springs, who was working with harmonics. So we collaborated on a project, and I had my students do research where we exposed in culture, right? We exposed spirochetes in culture to Rife machine, no Rife machine, antibiotics, no antibiotics, a bunch of other things. And that research was very successful. And actually, I had students take that research to international scientific conferences to present. So, basically what I showed was that the Rife machine in combination with antibiotics in test tube could kill the spirochete, could stop them from growing. And it was actually lethal to them. So it wasn't just putting them into suspended animation, it was able to kill them. Right. So that part, that was what I was doing myself in my lab. And then once I started working with Tammy, we connected with TGen, right, Translational Genomics Institute, to try to do a diagnostic based on RNA-seq, which is a sequencing method for RNA, which was different than the other sequencing methods. We also reached out, we've worked with, basically we have funded studies in pretty much every area where there's a possibility of a diagnostic test coming out of it. We've investigated that. So we looked at culture as a possibility. I actually did that in my own laboratory, right? Trying to come up with a better way to culture them, so that, because that is the gold standard, right? If you can culture them from somebody's body, then they are present, and antibiotics actually has a place for that. But we worked with various other laboratories. We've contracted to do some RNA work with other laboratories, with Galaxy Labs, with Tulane. And at the end of the day, Drexel University, we actually had them do whole genome sequencing, which was basically to look for every possible bit of pathogen DNA that might be in somebody's blood. And at the end of the day, we took all that and synthesized it down to where we are now. So, there's a lot of individual projects. There's probably 5 or 6 of them that all came, we evaluated them and said, this is what has the most promise. And I got to tell you that for diagnostics, because it is not just one disease, because, we're talking about early acute, we're talking about early disseminated, then later disseminated stages. These are different diseases, right? And by disease, I mean the illness that the patients experience. It's different. And what we're finding out is physiologically, it is different. Serologically, it is different. Gene expression wise, it is different. So all that came together, and that's where we're at now, with our, pending diagnostic, which, I always, Tammy and I have a joke. It's like, we're going to name the company Next Week Diagnostics, because all the results are coming next week, right? Or so it's, but we're, so like next week we're going to have results, but I think it's fair to say within the next couple of months, I'll be able to report back and say, we're really someplace with this, and we're going to take it forward. So
do you think a 100% accurate diagnostic test will ever be possible?
No, I really don't. But I think we can get pretty darn close. And, accuracy is a funny word, because accuracy, there's, sensitivity and specificity. So you want to make sure you don't have any false negatives, but you also don't want any false positives. So, but the point being, people are too different. And in other words, our immune responses are different. The bacteria interact with our immune responses differently. So I really don't think that any one test is going to be the one size fits all that gives, the full answer. And that we pretty much concluded that it's a multi-pronged approach. So maybe one for early, one for later kind of thing, because one test is not going to cover all the bases.
What did your colleagues think when you told them about the kind of research that you were doing?
My colleagues, where? Which colleagues?
Yeah. At the university where you're housed, your other research colleagues, other scientists. Has your work been well received by them? Do they think it's interesting?
Yeah, they do. They think it's very interesting. And, they also think I'm a little crazy, but, who doesn't? So that's perfectly fine too. Because, I'm at a college, right? So our focus is education, and it's, getting students interested in a treat and wanting to go on to get your PhD and do all that stuff. So, but, the fact that I've been able to engage undergraduates in this research is, a lot of people have a lot of respect for that. I don't know that not everybody fully understands the stakes, because I can tell you that my colleagues that have Lyme disease or have family or friends that have Lyme disease get it and understand the issues. So, everybody's been really super supportive of that. And in the rest of the world of Lyme research, I would say we have collaborated with everybody, and, it's quite a team. So the Lyme researchers is not that many yet, although that's going to change too, because now there's funding for fellows, right? Medical fellows to get medical training in Lyme disease at Johns Hopkins University, for example, and other places. So I think that's going to change too. But, the community of Lyme researchers are doing great work and supporting each other as best we can. And the good news, new ones are coming in. So I'm happy about all that too.
Tell us about the most exciting discovery you've encountered most recently.
The most exciting discovery would be, I think, the fact that there are ways to detect what our bodies are doing in response to infection with this bacteria. And by what our bodies are doing, I'm talking about gene expression. So in other words, turning some genes on, turning some genes off. Now we have tools that allow us to, fine tune that. And I have to say, one of those tools, which I have not worked with, but one of them is really intriguing to me, is a technology called CRISPR. I don't know if you are.
Yes.
Right. So, that's the latest shiny object. It's like, oh, CRISPR is going to solve the world's problems. But, we thought that it doesn't always work out that way. It's not going to solve every problem, but it certainly is intriguing to look at that. And I know the CDC is actually funding studies related to using CRISPR for a diagnostic test, which would be a direct test, right? There are ways to detect how the immune system is responding by looking at gene expression. And the good news is, if we can figure out, what genes are being turned off or turned on, now we have the ability to go back there and reverse that, right? So if the bacteria are shutting down certain types of genes because they want our immune system to be screwed up, technically we can block them from doing that, technically, right? Theoretically, we can block them from doing that. And, we're at a point with one of the biomarkers that we're working with that's, the next step would be to take that to let's see if we can make a therapeutic out of it. And we're not the only ones looking at that, but, the point being, one thing I have learned is working with different universities is that the process is long and tedious. Translation of research discoveries made in a university requires an outside interest to come in and say, I want that technology. I'm going to license it. We're going to take it to the commercial levels. So although there's tons and tons of research, not a whole lot is translated into, the patient space, right? Where it's going to make a difference in patients' lives. So we learned that certainly the hard way, and we'll be sharing that with everybody. It's like, okay, so there's this great research, go after it, right? Go get it, take it out of the university and move forward with it. And that's actually what we're working on too, is to be, universities are tough, they just, everything goes kind of slowly, but I work for a huge system, SUNY, so I get it. But on the other hand, like I said, we're all impatient. We want results. So if we have to do it ourselves, we'll do it ourselves.
There are a few animals known to kill Borrelia within their body systems. There are certain lizards, for example, that if are bit by a tick, that they have the ability to kill the bacteria. Is there any research being done around those animals and their makeup that might give us some clues as to how we might be able to do the same thing?
Yeah, so I read those papers when they came out about and they're, so people were kind of looking at them, but remember, lizards are reptiles. And
opossum, I think, is another one. Opossums?
Yeah, right. But opossums are just good tick eaters, right? Okay. I think that what they do is they are very happy to chomp on the ticks when they get attached. So in other words, they remove them and eat them. So that maybe that would be the approach. We just have to find the ticks and, just chew them. Anyway.
When I was sick for a long time, I started to ask a lot of metaphysical questions, and I started to ask questions like why, how, what is the purpose for this, right? Because Even if we consider the numbers, the CDC is willing to admit 300,000 cases a year. But if you do the math on this, the predominant tests used to diagnose the Lyme disease are only 50% accurate, which means the real number is probably around 600,000. So in the last 10 years, we have millions and millions of Americans that are sick, that are not being treated, they're not being taken care of, and they've been gaslit left and right by physicians. I most recently was gaslit by a neurologist. My trajectory was, I went to Cape Cod with friends. I had the bullseye rash, but didn't know what it was. Then I developed a huge rash on the inside of my thighs and got very sick, started having seizures, brain fevers, inability to regulate my body's temperature, 1,000 bee stings all over my body. The first doctor I went to was a neurologist, and I said, I think I may have Lyme disease. He waved his hand in my face and said, you don't have Lyme disease. And then did a MRI on me and said that I did not have any lesions on my brain, yet I had lesions on my brain on a previous test. Well, I waited, so it took me 24 months to get to find out that I was truly positive for Lyme disease, and then anecdotally, most likely Babesia and Bartonella, but I have not had the test to determine those two for sure.
Why not? Why haven't you had that test done?
Well, I just did in the test. I came back positive for Babesia, and I had the antibodies for Bartonella, and so we're doing that. But so I left Western medicine because it let me down. It took me two years, and I finally got the diagnosis. Nothing's covered by insurance. At this point, I'm $200,000 unreimbursed of my own money. If I was a checker at Walmart, I'd be dead today. I happen to have money so I can fund my treatment, right? So I left Western medicine, went to naturopathic medicine, discovered Focus on Lyme, Dr. Horowitz, the physician here in Arizona that treats me, who I will not name. And then, 11 years has gone by. I decided to go back to Western medicine, largely because of my insurance requires me to have a general practitioner. So I went back to a neurologist. So it's been 11 years since the first time I went. I went to a neurologist who walked in the door, who had already diagnosed me before even seeing me, who diagnosed me by, she did the physical exam with the hammer on the knee and had me walk down a hallway, and that's how she diagnosed me. She used the MRI from the previous neurologist. How she got access to it, I don't know. It was not I don't remember giving permission, but she somehow had that, and then diagnosed me, said I did not have MS, and gave me a 20-minute lecture on how the environment is filled with bacteria and viruses, and that doesn't necessarily mean you're infected with them. Okay, so for patients who are suffering from any kind of chronic and potentially terminal illness, we know that mindset is important.
Yeah.
To be continuously gaslit by the medical community it is beyond unethical, right? She did not offer to do another MRI. She wouldn't even entertain an idea of pursuing any other kind of test because I have seizures. Didn't seem to be important to her. So I ended up leaving that experience feeling all of the trauma response that I had from the last 11 years. Mm-hmm. So for us, we are so thankful for you and the work that you're doing, because I think that diagnostic tool is going to take the politics out of all of this stuff. Because for me as a patient, you can't help but walk away from an experience like that thinking there's a conspiracy theory going on, mm-hmm. that something is going on, that there's some collusion going on to kind of push the patients down, make them think it's all in their head, and get them out the door.
Well, Tony, let's talk about that a little bit, because I think you're getting to the same, we're sort of coming right back to that point we were coming to before with the research, right? And I think there is a conspiracy, right? And the conspiracy, unfortunately, is not at the clinical level, which is where most of our guests believe that it is. And I think you're arguing that it's at the clinical level as well. I'm arguing it's at the research level, right? And what's happening when you have the gatekeepers at the research level preventing any type of research from being published, other than those that fit within the parameters of defining Lyme the way they're defining it. What happens is that doctors then have to step out of the standard of care that they're required to utilize and then put their licenses at risk, right? So there is a conspiracy, but the conspiracy is between insurance companies and the research that's being funded and the gatekeepers or the boards of these medical journals, and probably pharmaceutical companies, which we only started to touch upon with Dr. Ahern before. So there is a conspiracy, but I don't think I don't think it's really that, well-intentioned doctors who want to come into the community and help people get better are the ones that are a part of that conspiracy. I think they're a victim of the conspiracy as much as the patients are. I think it's really happening at that higher level. And I'm just wondering, if the two of you could talk about that a little bit.
Yeah, I don't disagree with that. As I said, the doctors that I have spoken with, and I've spoken with a lot of them because on my educational tours, I hope to talk to physicians, and I have reached out to several to just get the perspective. Why are you viewing this as, just some sort of medical mystery as opposed to the most obvious explanation, which is this Lyme disease? And, what they just tell me is we need tools, right? That's what, what they want is a diagnostic test to say yes or no. And so I don't blame them because they are following the rules, the way that there's a standard of care, you follow the standard of care, that way you are protected, you are following evidence-based, this whole idea of evidence-based medicine, to which I say, yes, but what evidence are you using? Because the problem is the evidence that the IDSA guidelines are based on. The writers of those guidelines, as you mentioned, Rich, are the same people that published those papers who basically said, Lyme disease is a bullseye rash, and if you don't have it, you don't have Lyme, so that part is, and unfortunately those players are still in position. So,
of power,
I mean,
right?
the other good news is they're in their 70s, so one can only hope that they will eventually decide, I don't really want to do this anymore. And I think at that point, because they serve as a roadblock. I mean, honestly,
Yeah.
dogma serves as a roadblock to change it. Science is not like that. Science is not roadblock. Science is always saying, there's more science, that, nothing is ever settled. We got to keep looking, even when we think it is. But when you have guidelines that are like written in stone, it's harder for them to get around, I guess. I don't know how else to put it.
So, but there's another piece of this, Tony. You were talking about mindset and the importance of mindset, right? And of course, mindset controls cognition, right? Theory, which is nothing more than a belief, will control cognition. And when you have these doctors, again, who are well-intentioned people, I don't think people go to medical school other than because they want to help people who are sick, right? They want to get people out of pain. That's why they go to medical school. And what happens is that when they're given this specific training based on the limitations that the research gatekeepers are limiting them to, that belief in their head is what's now controlling the cognition. So what's happening in the patient community is you're feeling gaslit because these medical professionals literally can't see what's right in front of them. But the reason they can't see what's not in front of them is not only because they're incentivized not to see it, but because their mindset is limiting their cognition. And that's why we have this conflict. And what we have when we interview doctors is they're just burning out because they become doctors because they want to help people. They become doctors because they want to end suffering, and they know they're not doing it. And when you put those two things together, it's resulting in burnout, and the system's failing for everyone. And so many good doctors are leaving, the medical profession because they know they're not helping. And so part of, Tony, part of what I'd like you to think about and maybe react to unwashed now, but maybe we can talk about this even more in the future, is how much of this is really driven by the mindset of the medical professionals based on their training and based on their continuing education that's limiting them because the full breadth of research is not available to them?
There's ways around that.
Please share.
I like to use this example. If you've ever heard of the ACEs report, it measures adverse childhood experiences, and they can quantify that if a child has this many adverse childhood experiences, the propensity for obesity, alcoholism, incarceration, divorce, murder goes up, and they can track and they can tell you literally, what's going to happen to a community of children, especially where they have high incidences of adverse child experiences. Bullying is it's a pandemic. It's everywhere, right? And so we were focused on preventing bullying in schools, and it was so politicized, and it was turned into this big thing that the LGBT community is trying to indoctrinate people. The legislature went nuts, and we had an anti-bullying piece of legislation that got killed in committee. And then they passed a no homo promo law where you're not allowed to talk about being gay in K through 12, right? So all we wanted to do was protect children. So ultimately what we ended up doing was saying, the hell with that. And we went school district by school district. We presented the best evidence-based program that had a long-term impact on school climate. And the best program is the Olveus method, which is basically you remove all of the opportunities for bullying. Every bus stop, every bus, every bathroom, every cafeteria, every hallway, it's all monitored, right? The same approach could be for here.
For sure.
If we had a diagnostic, maybe we're going around by this backwards. If we had a tool to prove people were dying from Lyme disease, then that could compel action. But we're focusing on a tool to identify if someone has Lyme disease so they can be treated by a community that has no idea how to treat them.
Whose mindset.
So maybe if we show that these people die, this many people die in America from Lyme disease, maybe someone will listen. Now, my question for you, Professor, is do you think Congress is fully versed on this?
Fully versed, probably. I mean, some of them are more versed than others, but I have to say, you are probably familiar with the work of the Tick-Borne Disease Working Group.
Yes.
The last report was just dropped. I don't know if you know that or not, but one of the sections, subcommittees that was in this most recent group was the patient access to care. It was actually, access to care, which a lot of these things were investigated and recommendations were made. And one thing about the Tick-Borne Disease Working Group, it is a report to Congress. So in other words, this is all going to go to Congress. Congress will respond by, asking for appropriations for more funding, or perhaps, advocating with the CDC that maybe they need to, broaden their definition to include more chronic Lyme disease, whatever. But I believe that Congress is hearing this, especially with the work of the Center for Lyme Action lobbying. We just had a big lobby day. I don't know if either of you participated in that, but I did, where we, basically they organized it all, and we, 350 people participated. Actually, it was more than that. It was almost 400 people, which, the first year was about 60. And then the next year it went up to, just under 200. The third year was COVID-ness, so that, was kind of weird. But then this past year, almost 400 people did it. So as more and more advocates come on board to do that kind of advocating, more and more legislators are hearing about these issues, and they are responding by appropriating more money, right? So, I mean, that's the mission of the Center for Lyme Action, is to increase funding for Lyme disease, which is good. That part is important, but I also think we need to somehow get the CDC to move into, to appreciate the research that has already been done, and that's clearly showing that this is more than just a simple disease that's characterized all the time by a bullseye rash. I mean, that stupid rule about the bullseye rash appearing 70 to 80% of the time is so wrong. I mean, I can't even tell you how wrong it is, but they're still in that space. They're making little changes. I don't know if you guys are paying attention to that, but I do all the time, right? So the changes in language in the CDC, if you go check out their website or if you talk to their representatives, it is changing, but it's not changing super fast. And I think Congress can actually help with that too, right? So they can actually say, look at, you need to pay more attention. You need to include chronic Lyme as part of that. Oh, one thing about the patient access to care, I don't know if you've read that subcommittee report. I was actually a member of that subcommittee. That report, and this is historic, and this is hopefully will be a very moving thing, but in the term post-treatment Lyme disease syndrome, okay, so that word has ticked off a lot of people for very good reasons, because it's Lyme disease, post-treatment Lyme disease, and then it's a syndrome. So basically what they're saying is, we don't know what's causing it. We don't know what it's about. It's medically unexplained, but here's what it is. And that ticks patients off, as you might expect, right? It ticked me off too. So in this report, we were able to convince both the federal folks and the people in CDC to change that from PTLDS, post-treatment Lyme disease syndrome, to persistent Lyme disease / chronic Lyme disease. So PLD, CLD. And that is earth-shattering. I mean, honestly,
absolutely, that's huge.
That's on the federal side, right? That was the last stronghold has just been dropped. So now it is we're saying that there are people that get Lyme disease that have persistent symptoms that become chronic, and it's not a syndrome. It's not medically unexplained. We may not know what it is, but it's real. It's validating. And to me, that was, when you read that, and I'm, for going forward for the future, use those terms. I mean, I've advised everybody I know, don't call it post-treatment Lyme disease syndrome or post-treatment Lyme disease or whatever you want to call it, because that actually only applies to people who are diagnosed early and treated early. And then 15% of them still end up with chronic illness. But, like my daughter, like Tony, I mean, it was months before, so it's not post-treatment. Yes, she was treated with antibiotic and didn't get better, but it's because she wasn't diagnosed at the time of her tick bite. She wasn't treated at that point.
Right.
And that's the thing that drives me crazy with that, because the definition of post-treatment Lyme disease is you're diagnosed within the first week, treated with 2 weeks or 3 weeks of doxycycline, but yet you have symptoms for 6 months or more.
Right.
And if you aren't diagnosed within the first week, then you don't even belong in that category, So, and that's what that language change actually does. So just so you know, believe it or not, letters matter.
Yes,
Words
and
matter.
it actually does. And thank you for your great work, on that committee. And it matters. I think it matters in a lot of different areas, but it matters where research dollars are going to be spent. It matters where insurance companies are going to be covering care. It matters where we're going to be defining the type of treatment that doctors are going to be using. It matters in every way, shape, or form, which sort of is a nice way of sort of winding down as we get to the end of the podcast. What we started with was, how do you define Lyme disease, right? And because language matters and definitions matter, and now that we're getting to a point where we're using language that's consistent with patient experiences, and we're using terms that allow us to create a target, that is everything. That is huge, and it is going to be making changes, real practical changes in the lives of people like Tony. So Tony, as the special co-host, you get to ask the final question. So I'm going to let you do that now. What is the final question that you'd like to ask before we have a conversation about takeaways?
What is giving you the greatest hope right now?
Great question.
Yes, sir.
Momentum. Honestly, within the past, 22 into 23, I have to say that one thing that really helped a lot also was the Lyme X challenge. I don't know if you were familiar with that. It was a prize. The first part of it was a prize challenge for a diagnostic prize. There were 46 entries in that. All right. So only 10 of them were awarded funding for that. I was also a judge for the for the Lyme X challenge. That's why I know that there were 46, entries for this. And that, that was phenomenal. And they were good proposals, so there were a lot of really good ideas out there. There are definitely researchers who are interested because, not all of them came from the same place. Not all of them were researchers at universities or whatever. Some of them were commercial already, manufacturers and whatever that wanted to do it. So I really, as I mentioned, feel that the rock, we're almost there. We're almost ready for the rock to start rolling downhill with all of these things that are finally coming together. Everybody's hard work and concern and advocacy, and even individual patients who are reaching out to other people. The network is growing, the network of Lyme disease patients and patient advocates, and I think that what will follow from that is changes in the standard of care, especially after there's an accurate diagnostic test. There'll be changes in the standard of care, may be a little bit slower coming, but nonetheless, I think there's progress being made, and we actually have a wind behind our sails pushing us at this point, instead of just floating around there in the middle of the ocean, like, what the heck?
Yeah, so I think from a takeaway standpoint, I'd like to get your reaction to a couple of things, because I think we had some feisty debate here on this podcast, and there are a lot of things that we identified that have been problematic as we've been going on this journey together as advocates. But there really are a lot of really positive things that we've learned here through this podcast today. And so one of the first things that I think is really exciting is that so many of the gatekeepers who have been preventing important research from being available to mothers like you, Dr. Ahern, and other people who are looking to get their hands on research, those guys are dying, and they won't be the gatekeepers for much longer. So I think that's a really very exciting takeaway. Another really exciting takeaway for me is that you pointed out that many of these patient organizations are doing a great deal of work in raising money and funding, really important research, which is now opening the door for other types of research. And one of the patient organizations, or one of the patient funding sources, of course, is the Cohen Foundation, which you were just referencing with the Lyme X project. Fortunately, unfortunately, when billionaires get Lyme disease and they decide they're going to dedicate some of their resources to research, we have the kind of projects like Lyme X. So, the totality of all of that work that's being done on the fundraising side from patients like the Cohens and like the various other not-for-profits that you defined are beginning to get to the point where we're getting to a place of momentum, which is really exciting. I do want to point out a couple of other things that we've talked about in the past, and you've given me new insight into something that we had never thought of before, which is, we've always said that that the gains that have been made in the Lyme community have largely been driven by moms, right? Unfortunately, not dads, largely by moms. And moms have been doing really, really great work. And if you look at the sort of the genesis, a lot of the great not-for-profits and a lot of the advocacy work has really been by moms and people who are parenting Lyme, including, by the way, LymeDisease.org, which is one of the few that you had available to you when your child first got sick, right?
And LDA also.
Yeah. So we see moms doing great work. So we really have a lot of hope when we interview moms and we see how they're parenting their children. In many cases, their children have become leaders in this community, and they've become the doctors who are doing some of the great work. I think of Dr. Casey Kelly, for example, is one of the brilliant young leaders in this community who went on her own journey with Lyme disease and is doing some of the great work despite being very young. She's a very young woman, right? But what we hadn't seen before you is how you're using your influence, not only with your own child, but many other people's children who are coming to study under you. And you're now encouraging them and giving them, some career direction, some mentoring that's bringing them into the Lyme community as well. So it's not just moms who are parenting children with Lyme, but now we have a mom who's parenting other people's children or mentoring other people's children as a professor, and that's really awesome as well. And I think these young people are the ones that are really going to get that boulder running downhill. So as great as it's been for, so many of the moms who have done fantastic work, and so much of the research that is being done as a result of patient advocacy work, it's really these young people who are now aging into, their professional lives, and they're going to make that change. And I think that's why, we should all have a lot of hope. So I want to thank
have more opportunities to do that with more funding.
For
It
sure.
draws more people into the field. And, I honestly feel like one of the reasons why, HIV and Lyme happened at about the same time.
Yeah.
And everything went to HIV, right? And, so Lyme sort of got shoved off into the background. And, but I really feel that at this stage, we have made it to the point where there's enough people, in the interest. And what I'm trying to say is, all the funding went to HIV, but now we're getting there. We're nowhere near where we should be, but we are getting there. And that's going to draw young blood into the research arena and into the medical community, which is really what we need more than anything, are doctors that actually are versed on not just the IDSA version of what Lyme disease is, but actually understand that it's a more complicated illness.
Yeah, and these diseases did certainly crop up at the same time, but the reason the HIV world was more successful, quite frankly, is because they were just better at advocating and building a model to bring resources to deal with a public health crisis. And the good thing about having those folks is we have a model. We can follow them because they taught it. They can teach us how to do it successfully. So there are so many really wonderful things that are happening and so many great things on the horizon. And I'm hoping folks are leaving this podcast not only feeling blessed by listening to you two brilliant people, describe so much of what your experiences were, both together and as individuals, but also because there really is a lot of great things happening, and we have a lot to be hopeful for. So again, I can't thank the two of you enough for taking so much time out of your really busy lives and sharing these great stories with us. And I know folks are really going to be excited to follow the two of you and follow the work that you're doing, moving forward in these communities.
Thank you, Rich. Appreciate that.
Professor, thank you, Rich.
Thank you for listening to our Tick Bootcamp interview with our guest, Professor Holly Ahern. To our listeners, we have a call to action. First, if you'd like to learn more about Professor Ahern, please visit the State University of New York Adirondack website. Second, if you enjoyed this episode of the Tick Bootcamp podcast, please share it with your friends on social media. Third, we here at Tick Bootcamp have created a Tick Bite Blueprint. It has been inspired by the information that has been shared with us by past guests on this podcast. We urge you to visit our website at tickbootcamp.com/bite to view the blueprint. Fourth, don't forget to subscribe to this podcast on Apple Podcasts, Google Podcasts, or Spotify to get your automatic episode updates of our Tick Bootcamp podcast. And finally, if you'd like to search our podcast library for almost 350 episodes, subscribe to our email list, or share feedback, please visit our website at tickbootcamp.com. Thank you, as always, for listening.